Hello everybody, welcome to the Pressure Injury Prevention and Healing PIP program overview here at Sequoia Hospital. My name is Gwen Jewell. I'm one of the nurses here, and I'm here to tell you how we at Sequoia managed to get our hospital-acquired pressure injury rates down to less than 1% and our reportable pressure injuries down to less than 1 per year. So I think you'll enjoy it. Buckle up and get ready. Okay, there are 7 steps to our PIP protocol. First and most important, we have to determine who is at risk for pressure injury. So do a bedside risk assessment and a full skin check every shift. Remember that often the patient's condition changes, so don't be fooled. If the patient was not determined to be at risk when they were first admitted, you still need to do it every shift because the patient condition changes. If you determine that the patient is at risk, order a skin care order for all PIP risk patients. If you see a wound on your skin check, please photograph all suspected pressure injuries or worsening pressure injuries upon discovery. Order a wound care clinician eval and treat if you see a pressure injury. You can order a wound clinician eval and treat for any wound if you think you need one, but definitely order it if you see a suspected pressure injury. Please use the MD verbal order readback or telephone order readback for those orders. Now, the fourth thing would be to tag and notify all PIP patients. You post the PIP sign, put a wristband on them, inform the aides, charge nurse, and the next shift, of course. Now we can start, for all PIP patients, start routine PIP interventions, the turning and repositioning, floating the heels, patting and protecting other parts, and pericare at least Q4. Offloading pressure would be to offload the lower back, the heels, and any other body part that is exposed to pressure, especially in a seating position or pressure from the bed rail or devices. We want to prevent moisture from contacting the skin. We're pretty good here about keeping moisture off the skin with the equipment and supplies we use, but if you're having trouble keeping the skin clean and dry, you'll need to do that more often. Prevent friction and shear. That means prevent slipping, sliding, slumping, friction, and shear. The PIP skin and wound check. All patients should have a skin check Q shift, but patients who are under PIP protocol should have the skin and wounds checked often, at each opportunity, really, if you can remember. Every time you turn and reposition or do the pericare or have to transfer the patient, ambulate, or return from procedure are times where you really need to check the skin. The sooner you can catch it, the sooner you can nip it in the bud and prevent it from getting worse. Chart your interventions. There is a free text box. We're not going to go over all the charting here, but there's a free text box or event note to chart complications and chart your work, of course. Above and beyond everything else, the most significant risk factor for pressure injuries is having a wound over a bony prominence or some signs of irritation. Most of the time when you see signs of irritation over a bony prominence, it's either a pressure wound or a precursor to pressure wounds. So if you see this, the patient should be on PIP protocol regardless of what the diagnosis of the wound is. I think a lot of times we were having a lot of trouble with people sort of the first assessment of what the skin looked like sort of stuck, and everybody just assumed that the skin was still like that 4 or 5 days later, and that's definitely not the case with PIP patients. So when you have a PIP patient, you need to check it at every opportunity, especially during turning and repositioning or at pericare. The reason most hospitals like us use the Braden scoring to determine risk is because it's pretty accurate when you do it right. But the problem we were seeing is that nurses they kind of forget to do it at the bedside because we're doing so many other things, and they do it later in the computer, and the score becomes sort of an afterthought. So I'm going to ask you guys to think about Braden at the bedside when you go in there to assess or when you go in there for any other reason. So this is Braden, but it's a little bit different approach. First of all, what you need to determine is, can and does your patient protect their skin from pressure, from moisture, and from friction and shear? So how do we know our patient is at risk at the bedside? Well, simple. First, immobility, obviously. If they are unable to or do not move and position themselves off the pressure points easily and often, then they are at risk for pressure injury and require turning and repositioning. Moisture. Just because someone's incontinent doesn't mean that they're at risk. It's the people that allow their skin to be soiled with urine and stool, or they can't tell us, or they can't feel it. Those are the people that are at risk for skin damage and subsequent pressure injury. Also, people who are have weeping edema or have a lot of diaphoresis, if they can't get their linens clean and dry and clean those, then we'll have to do that for them before they get a pressure injury. Friction and shear. Does the patient often slide down without being able to correct themselves? They slump? Are they restless and causing friction and shear on their own skin? Do they require frequent boosting? Are they too heavy to lift during a boost? I see a lot of times that two caregivers will actually boost by sliding the patient because they're too heavy to lift. But this is actually too much friction on the patient and also too much weight for you guys to be sliding. So I do encourage you to use the lift equipment so that nobody gets hurt. If they cannot feel excessive pressure, moisture, or shearing because of medications, or maybe they're sedated, or they have neurological disorders like spinal cord injury or that kind of thing. If they can't tell you and feel, then they won't be able to move off of it even if they could. Is the skin fragile? The skin check will tell you everything. A lot of people get pressure injuries because their skin is fragile, even though it's not a lot of pressure or a lot of moisture. So most of the time it's from poor nutrition, advanced age, or the patient has poor health from kidney failure or cardiac disease or any number of things. But you really don't have to worry about it. What you have to do is notice if the skin is fragile or is starting to break down, then your person's at risk for pressure injury. And of course, if there's signs of skin damage over the bony prominences, most of the time it's either skin damage from a pressure injury or it's a precursor to a pressure injury. Mobility and activity are the most important things to check, and fortunately you can do it pretty quick at the bedside. But I do see a little confusion between the definitions of mobility and activity. Like I'll say, hey, is your patient at risk for pressure injury? And they'll say, no, because I can get them up to the chair and I walked them to the bathroom and they can do it. So no, they're not at risk. No, actually, we need to determine exactly how active they are. So first of all, the difference really is that mobility means the patient is able to turn and rest in a side position or able to turn and offload whenever they want to. They can also lift their heels and for the purpose of relieving pressure or adjusting their body position. Activity means the patient can change position but does not. Inactivity means they may be able to change position, but really when they're in bed, they're actually not changing position. Overactivity means when somebody
to test a person's mobility at the bedside, lower the head to bed to flat and ask them to turn. Don't help them or push or anything. If they lift their shoulder, obviously they're not offloading their sacrum buttocks area, and obviously they're not mobile enough to offload the pressure points. Sometimes they'll actually be able to turn just a little bit, lift their hips up off the bed, but when they let go, they flop back down and right on their back again. Obviously, if they can't turn and rest on their side, they should be put on PIP protocol. Sometimes a person can turn and lay on their side upon command, but when they're not asked to do so, they stay in one position. This is why you should consider the patient's activity as well. When people are healthy, they lift, shift, turn almost constantly while they're laying in bed because our sensation, reflexes, and mobility is enough to know when it's time to offload pressure. But when a person doesn't move for the duration of while they're lying in bed, their activity is low and their pressure points are not being offloaded. Sometimes the activity level is a clinical judgment call because it's hard to know what they're doing when you're not in the room. But if they're in the same position they were in last time you were in the room, that's a hint. When in doubt, you'll have to watch the skin closely over bony prominences to make sure there's no signs of irritation or wounding at every turn and every pericare. If you see signs, you're going to have to do the turning and repositioning more often. When in doubt, you'll have to watch the skin closely over bony prominences to make sure there's no signs of irritation or wounding at every turn and every pericare. If you see signs, you're going to have to do the turning and repositioning more often. The other factors you can check at the bedside the same way. Remember that
turning and repositioning in PIP care is really not an every 2-hour thing or an every 4-hour thing. It should be done at a minimum of 4 hours, but really you need to fold it into your workday and fold it into your routine. You don't have time to just stop what you're doing and run to a room and turn somebody every 2 hours, but you can see when they need some care. Out of position is the most significant thing. It's most obvious if the wedge is slipped out and they're back on their pressure wound. If they're slumping down, slumping is the worst position for a patient to be in, because not only do they damage their back, they put excessive pressure on their sacrum. They can't breathe as well. They can't digest as well, and usually they start to flop back over, and there's a lot of friction and shear. So slumping needs to be corrected ASAP. Obviously, if their heels are touching the bed because the pillow's bottomed out or something, or the patient moved their legs, that needs to be corrected. A lot of times you can correct that right away. Again, of course, moisture. You can check for moisture for urine, stool, and sweat, usually pretty quickly, and identify when the patient needs to be cleaned up. And of course, you probably can't just drop everything and fix it right then and there, but at least when you're aware, you can start making a plan for how to get some help or whatever, or decide when you're going to get it done. Repeated sliding. If you've got a patient that's on a slider that just keeps sliding down, or if they're constantly needing boosting, maybe there's some upgrade you can do. If you have trouble with the patient handling, certainly call wound care or physical therapy, and we can see what we can do to help. And I can't say it enough, if their skin is damaged, especially over bony prominences, look for the skin, look at the skin every chance you get. If it's damaged, they are at risk. Okay, this is the easy part. Tag and notify about all PIP patients. First of all, post the sign. The PIP sign is green. It goes outside the door, or tape it up there. The PIP sign has the entire list of possible things you could be doing for your PIP patient. Obviously, you want to modify it to suit your patient's specific needs, but the entire list is right there on the sign. Apply a wristband so that everybody sees that this patient is at risk or maybe has a pressure injury. And tell the aides that the patient is a PIP patient and therefore needs all the PIP interventions. At our hospital, any person can initiate a turning and repositioning or a pericare. I know a lot of people didn't get into nursing because they couldn't wait to clean urine and stool, but you know, the patients need you, and your team needs each other. So everybody, please work together to get this work done. It's very important. Tell the charge nurse so that we have an ongoing list of who's at one of the PIP patients are. And again, order the skincare order with a telephone order readback or a verbal order readback from the doctor. And of course, initiate the skincare plan. Just get started. Look at your list, decide what you need to do for the patient, gather the supplies, and start pipping. Okay, so we want a photograph of all suspected pressure injuries upon discovery or obvious pressure injuries. You can feel free to take a photograph of any wound, but the only ones that are required to photograph are the pressure injuries. There's a phone in each unit. Have somebody help you the first time to take the picture. You want to take a picture upon discovery and if ordered. Now we order wound photos because, not to punish everybody, but in the case that we need to carefully document the progress of the wound or prove that we are what we're doing is working to heal the wound. So please look at your wound care orders and make sure you notice if we're asking for a photograph to be taken every day. And obviously, if it's getting worse, especially if you have photographs from the past, if you think it's getting worse, take another photo and let wound care know. Supporting the turn position is a little tricky, so we're going to go over the basics here. Remember that we're trying to offload the sacrum coccyx area especially, and maybe the side of the buttocks that has a wound, by supporting the person in a turn position about 30 degrees lateral. If a patient can tolerate being in a turn greater than 30 degrees, great, then that's what they should do. We should support them that way. We should use the wedge for patients that are over 100 pounds because pillows tend to bottom out, and I can't tell you how many times the caregiver thinks they've got the patient turned because they're using pillows, but you walk in there and there's actually no pressure relief from their sacrum coccyx because they've scooched down and bottomed out the pillows. Work with the patient because turning 30 degrees is probably the least most patients really don't like to turn, but it's so important to prevent pressure injuries and also for mobility, so it's really good for them. So work with the patients, don't just give up right away. Talk to them and try to make them as comfortable as possible, and do notify wound care or PT if you're having complications with the turning, as there could be many.
Okay, now you're ready to turn and set the wedge. You're always going to get a much better set when the patient is fully straight and parallel to the bed and closer to one side. Bend the knee and turn them over. Now the wedge can be set under the underpad, but for demonstrative purposes, we're going to set the wedge over the pad. Because when you do that, it's a lot easier to see where you're setting the wedge and where it's going to lift from the body, and it's a lot easier to get it under her. Notice how Lisa tucks it under. That makes it a lot more stable. And when she rolls back, the wedge is all the way underneath her and she's resting on top of it. It doesn't work to try to punch the wedge closer once the patient's laying on top of it. So if you want the wedge closer, you'll have to reset it. Setting the wedge to lift from the buttocks and scapula is best when the patient can rest supine, and it mostly circumvents the spine and the coccyx. Here is a standing view of how to set the supine resting wedge. If the patient must rest in the head of the bed greater than 30 degrees, then it's better to set the wedge a little bit lower so it's lifting under the sit bones and the back, just about like this. Or if you're trying to avoid a large wound, you have a heavier patient, or they won't let you turn their back, you can set it very low so that it's lifting only the hips. When side turning is not possible for whatever reason, you can put a wedge on both sides, although this is more difficult and it doesn't achieve complete pressure relief. Okay, so now that you've set the wedge where you want it, roll the patient back so that she's resting on top of it, and you can stand at the edge of the bed to make sure you've got the 30-degree angle that you're looking for. What's next, Kristen?
And you can see there's a lot of weight still on here, so we're truly not offloaded. So what we're asking you guys is to make sure is to, as soon as we bend that leg, you've offloaded the weight. So you can either bend the leg and they can keep it that way, you can use it, or you can use a pillow to support, like that. And you can, even if you have the leg fairly straight, like this, you've still got more offloading than if it was on the ground, or on the bed. Ideally, you have it pitched a little bit forward so that you're in a good alignment. All right, so we also want to make sure we place the heel bed, so we'll go ahead and raise up the legs, slide it under. Ideally getting the ankle area heel into the groove of the heel bed.
Okay. Okay, Kristen called it the heel bed or the foot bed. It's actually a low profile pad that's designed to lift just high enough to get their heels off the bed and support their ankles so that you're not interrupting blood flow as much. If the patient wants a pillow under their knees, then you can put a pillow under their knees. You can put a pillow on top of the footbed or lower, but this is designed to support the ankles. And as you rotate it, you can accommodate how the patient wants to keep their legs naturally. No matter what support device you use, you're going to have to keep adjusting it when you go into the room. So please take a few seconds to look and make sure their heels are floating, and if not, kind of lift up their legs and fix it. We don't use pillows because they bottom out. They're so much less reliable. And we're not using the foam boots anymore because we've had complications with them entangling the patient and actually leading to pressure wounds or disrupting dressings or causing excessive pressure. So we haven't gotten, we've got one stage 1 pressure injury from the heel since we started using this. So use it. It works really great and it's super easy. Okay, so we're not going to have time to go over all the charting, but let's suffice to say that you want your pressure injury prevention charting to be written in a defensive manner, as though you're defending your care to someone in a deposition. It's just the way it is right now. So we have a free text box in the other section. You can chart. There's 3 reasons pressure injury might happen. One, if the caregivers just can't get to it, their time or whatever, they just just don't get to it. 2, if we have trouble achieving pressure relief, trouble preventing friction shear, or trouble controlling the moisture. And 3, if the patient refuses turning or has some kind of combative thing. So whatever the story is, tell the story when you're having complications. This is a couple examples. 2 caregiver assist, a 30-degree lateral turn supported with a wedge. That's great. Or refuses turn due to back pain. We'll try again after pain medicine given. And then, go back and chart the results of the pain medicine and all that. Okay, so that's the best way that's the most important thing you need to know about charting your turning and repositioning. Okay, that's it in a nutshell. Thank you guys. Now go out there and turn. My name is Gwen Jewell. I am a clinical nurse too, registered nurse, and I do quality education and training for pressure injury prevention. I'm also the mad scientist behind the Bedsore Rescue Cushions and Pillows, the best cushions and pillows out there. Visit me at jewelnursingsolutions.com or call me if you're interested.